you, Professor, and all the audience. I glad to thank that all of you still here. The time quite constrained. I have only 15 minutes. So anyway, the easiest way for you to treat or manage hepatitis C in cirrhosis or decompensation is just refer to the hepatologist. You can see Professor Tira simplified the regimen of treatment: 8 weeks, 12 weeks, 16 weeks, 24 weeks, ribavirin and non-ribavirin. That's quite simple. I think after finish this, you'll probably refer to me or Professor Tira, quite easier. Hepatitis C is quite a big problem in all over the world. Actually, I focus on the patient who been on transplant list in US. You can see that nearly 1/3 of the case from hepatitis C in EU. The same thing, viral associated cirrhosis that waiting for transplantation, around 1/3 of the case. In Thailand, I have data from my unit. I correct the data from 128 cases for the last 10 years of transplant. The indication for transplantation is cirrhosis and hepatocellular carcinoma, actually half and half. If we look at the etiology of the disease, hepatitis C is among 1/3 of the cases, the same as in US and Europe. This is quite a summary slide for managing cirrhosis in hepatitis C. You have to know that it takes around 20 to 30 years from start of infection. Patients have asymptomatic of chronic hepatitis for 10 to 20 years and turn to have cirrhosis. We call compensated cirrhosis because they have no symptom, no edema or no sign that you can detect it. Once the patient progresses to the decompensated state, it takes 3 to 5 years until the patient dies. During that time, when people reach nearly 10 years, they will start to go on to the decompensation. They start to have a lot of complications we're going to show you later on. Patients going to have hepatocellular carcinoma in 50 to 60% of the case within 10 years, just before they start to have cirrhosis. For the clinician, if any one of you are here, you can see the assess the patient who have cirrhosis by they call Child-Pugh score, or we call Child-Pugh score A, B, and C. Once the patient become decompensation, we call Child B. The scoring is 7 to 9. Before they die, the score come up to 10 to 15. We call Child C. The new scoring system called MEL score, which originated in the US. The scoring system counts from 6 to 40. It can predict survival within 3 months. When the patient becomes nearly decompensation, the MEL score start to rising from 6 up to 40. We can predict that how many percent the patient will survive within 3 months. For the Child-Pugh score, we can predict for the 12 months of survival. Again, if we're going to do a liver biopsy on the patient, we heard Professor Tira talking about fibrosis score 1, 2, and 3. When patients have chronic hepatitis, the scoring of the scarring in the liver, we call F1, F2, F3. But when we begin to have cirrhosis, we call F4, which if you do the biopsy in the patient who have cirrhosis in any state, even in compensation or decompensation, the same thing we can see. They will have a scar, but they cannot tell how much the liver function. So we have to look at the MEL score or the Child-Pugh score. This is a list of complications from head to toe, as other any cause of cirrhosis can cause this kind of complication, which I'm not going to do in detail. When patients have cirrhosis from hepatitis C, this is quite a good data from Italy. 80% of the cases here come from hepatitis C within 15 years. So once they have cirrhosis, they have a lifelong of 10 to 15 years. In this data, 30 to 40% of them die within 15 years, and about 40% have hepatocellular carcinoma. Once they have cirrhosis, the common complication is ascites, hepatocellular carcinoma. At the later stage, they will have variceal bleeding. They have a portal hypertension and bleeding, and then some of them will have hepatic encephalopathy is this neurologic complication. So this is summary slide that once they have cirrhosis, they have annual mortality of 2 to 4%, decompensation within 6% within 1 year, and hepatocellular carcinoma, you can see 1 to 5%. 5% in 1 year, it means that if they live long for 10 years, they have like you can predict that they have 50% chance of getting cancer. You like a fortune teller when they sit in front of you at the proof cirrhosis, 50% chance of cancer within 10 years. So why we need to diagnose cirrhosis? Professor Tira already mentioned that we probably need ribavirin to add on the DA regimen. We probably have to extend the treatment regimen if they cannot take the ribavirin because it causes a lot of complications. Sometimes we have to make a decision that we're going to treat or not treat the patient, or we transplant them first and we treat later on. So this is not difficult. Any one of you who's sitting here can say that this is advanced cirrhosis, have big ascites, have leg, we call pitting edema. If they put the finger down, we call pitting edema on the leg. If we use the CT scan or MRI, you can see that quite easily to see the nodular surface of the liver. We can see the water in the tummy. But again, on the right side, this is a real person in my patient that we take it out when the patient doesn't have decompensation. This is the liver of the patient who have hepatitis cirrhosis, and they have hepatocellular carcinoma inside, 6 centimeters, we take it out. But the patient just walked to my clinic with the ultrasound saying that normal liver, but see the mass of 6 centimeters of hepatocellular carcinoma inside. But within 6 months, when we take the liver out, it looked like this. Because when you see the patient in front of you, you cannot say that they have cirrhosis. How much of the cirrhosis they have? This is a sample, example. So how can we diagnose the cirrhosis at the earliest stage without the symptom? So we can do a clinical screw by seeing the hand, let them show the hand and see the redness of the palmar area, we call palmar erythema. We can see the spider nevi on the upper part of the body. We can see the low platelet count for wrong now, which is quite in the late state of the cirrhosis. We have a lot of composite score, we call FIFO score, APRI score, which quite available. You can diagnose it alongside the bed, but again, it's quite in the late state of the disease. The standard imaging modality like ultrasound, CT scan, or MRI can diagnose cirrhosis. Actually, once they have cirrhosis for 8 to 10 years, the CT scan or MRI probably can detect the cirrhosis by the best imaging technique. So the best one of gold standard that we use is liver biopsy, which is quite risky. 1 in 15 have bleeding, 1 in 10,000 probably can be die from the biopsy. When you do biopsy, so what does this mean for F1 when the patient have chronic hepatitis? They have like the blue color in the middle of the picture, we call the F1 inside the portal area. When it's spread outside the portal area, it's called F2. When it's connect between portal area and centric lobular area, it's called septal, or it before the cirrhosis. Once it's around the liver nodule, we call cirrhosis, like the picture on the right side that I show you here. So if we're going to diagnose patients who have early state of cirrhosis, there are a lot of new modality we call elastography. So we have 3 ways of looking for the cirrhosis by elastography. The one that we already know and use quite often is called transient elastography. This is one-dimension transient elastography, the common available machine called the blinded fibroscan. The second one is called ultrasound elastography, which is 2-dimension shearing wave elastography. The last one is MRI elastography. This is the first one that we already know. The machine, they put the probe which punch out the vibration to the skin, to the liver, and the ultrasound can measure the shearing wave velocity. If the scoring come out below 6, we call it normal stiffness. If it's between 8 to 12.5, it's F3. If it's more than that, it's cirrhosis. If in between, it's F1 or F2, which quite in a gray area that is have quite false positive and false negative value quite a lot. So anything we probably need to detect the patient have scoring over 12 that we have to add library to the patient or not. This is an example of the result come out that we can tell that how much of the fat the patient have, how big of the liver stiffness they have. The newer modality actually in Chulalongkorn we actually use at the moment, we call two-dimension shearing wave elastography. It's quite different from the transient elastography because it can have a B-mode ultrasound. So the radiographer can see the picture of the liver where they can measure, they can see the color, visualize a color in quantitative way, so they can tell how much of the stiffness in that area. So the result come out the same as the FibroScan. The scoring system is nearly the same. If it's above 10 or 11, it's called cirrhosis. The last one called MR elastography, the principle is the same thing. The driver generates a radio frequency signal to the liver, and it's synchronized with the MRI frequency and can read out as the mode of liver stiffness. You can see from the example of this, they can see this, the scoring by quantity, the color. If it's a blue, it's state 0 to 1. If it's green, it's state 1. If it's yellow up, it's a state 3. If it's red, like on the right side, it's called state 4 cirrhosis. This one or this model is quite good because it can average the area of the liver in different cut of the liver. It's quite accurate in terms of diagnosis of cirrhosis. In Chulalongkorn Hospital, actually we done some clinical trial and see that it's quite, the MRE have a strong, significant strong correlation with the FibroScan or ultrasound elastography or with the clinical score. But again, if we're going to do MRI for the patient, it will take like 10 to 15 minutes more to do the elastography and cost more. In Thailand, probably another $100 to add on to measure the fibrosis. The DAA treatment in advanced cirrhosis, you can see, I can see that if the patient turn to have child C cirrhosis, this is the Ali1 solve the Cartasvir library for 12 weeks. The reduction of the SVR12 from 90 something to 56%. If the patient have the albumin below 2.8, we can predict that they have only half or 50% of SVR. Again, the data from SOFT-WELL for SOFT-WELL plus Liberin or SOFT-WELL for 24 weeks, you can see the genotype 3, which is common in Thailand. They have only 50 or 85% SVR. What happens if we treat the patient and if they respond to the treatment? You can see that this is a graph show that the arrow of each graph becoming down means that the patient have decreased the MEL score. After treatment finished, if we wait for this study show that within 4 to 12 weeks after end of treatment, we can see the improvement in liver function of the patient. This is data from Ledipasvir and Liberin. So the same thing that patient improve the MEL score within 4 weeks after the end of treatment. This is data from SOFT-WELL in patient with decompensated cirrhosis. If patient have baseline MEL below 15 or above 15, they can show that 50% to 80% of patients will improve their MEL score within 12 weeks after end of treatment. So what happens now is when we treat the patient who have decompensated cirrhosis from hepatitis C, some patient will be transplanted, some patient, that means this is 18% of this result show that we can delist the patient. That means patient improve from child C to child B and they can back to child A soon afterward. So I would like to end some data from my unit. This is the first cohort that we looking in the patient who have chronic hepatitis and compensated and decompensated cirrhosis. We have Sofosbuvir and the Cartas were approved 1.5 years ago. And the cost of the treatment in Thailand for 3 months is around 11,000 US dollar per 3 months. It's quite expensive. We conduct a trial for, I actually collect the data of 100 cases and show you today that we have all, my protocol is quite simple. All genotype we treat for 3 months. If the genotype 3 with cirrhosis is 6 months, if the patient have cirrhosis or post-liver transplant, I will add the ribavirin. If the patient have cirrhosis or post-liver transplant who cannot tolerate the ribavirin, I will extend the treatment to 6 months. This is quite a simplified protocol in my unit. During the treatment period of May 2016 to July 2017, I have 100 cases. Genotype 1 and 3 quite common in Thailand. We have 51% already have previous treatment with PEG interferon ribavirin. We have a lot of cases, 58% of compensated cirrhosis. Again, after end of treatment, we assess the SVR12 at the moment of the first 100 cases, 100%. We have incident of 1 case that after she killed from the treatment, she had flare up of the SLE, quite severe. Quite interestingly that before and after the treatment, I assessed for after 1 year of the treatment from the beginning to 48 weeks, we can see that the liver stiffness decreased significantly within 1 year. So I think that if the time finished now, I would like to summarize that if you want to dealing with the patient who have cirrhosis and they start to have decompensation, you have to looking for the idea that whether the patient need transplantation yet. The clinical clue is if the patient have refractory ascites, have spontaneous bacterial peritonitis, or this patient will die within 1 year. 50% of patients die. Child score C, male score of 15, cirrhosis or with hepatocellular carcinoma who have within the Milan criteria 1 lesion of 5 centimeters, 3 lesions of each lesion less than 3 centimeters. They don't have to have no vascular invasion. They have no extrahepatic metastasis. In my experience, we have a lot of hepatitis C that have been treated with the DAA regimen. Our data treat of the 24 cases of hepatitis C post-liver transplantation, 100% of them cured within 3 months of treatment. So the regimen, the only regimen that we have is the Cartasvir, Sofosbuvir, and ribavirin, quite effective in Thai population. I think I will finish at this time. Thank you very much.